Good evening. My name is Jim Greenblatt. I'm Chief Medical Officer, Walden Behavioral Care. And tonight, what I wanted to do is to kind of bring some of the concepts we've been talking about over the past couple of years about for integrative medicine for mental health into a review of how I used integrative medicine in my practice. So what I did a couple months ago is just put together a series of 6 or 7 cases that I've seen and want to share with you the thought process that are involved with that. And it really kind of identifies the concept of personalized medicine. Okay, so the first concept is really starting to explore our quest for perfection and what we're asking of ourselves as clinicians, but more importantly, what we're asking our patients. And this is just a very nice, well-written book by Deborah Spar, president of Barnard, talking about her struggle with perfectionism and how, as a culture and society, that's how we expect our kids. So we ask our patients, in many ways, that same concept of perfection, that you have to eat a certain way, exercise a certain way, relax, eat your vegetables, and all the kinds of expectations that we put on our patients. And I think we do the same thing for ourselves. We have a hard time taking time off, taking care of ourselves. Again, we have to be the best. So what I want to explore with you this evening is the concept of why a personalized understanding of our patients is so critical for the relationship you have with your patients as well as for optimizing treatment. So we recommend to our patients to exercise more and to eat a certain diet, and some patients can embrace it, some can't. We have individuals that live to 100 eating junk food, and other individuals become sick with hypertension, obesity, and diabetes. And in my world of eating disorders, I can have 5 14-year-olds who go on a diet, and 1 becomes anorexic on that quest to lose weight, and the 4 others are able to eat normally. So if we start to try to understand why, we go back to the core concepts of integrative medicine, which is biochemical individuality. This is a series of routine stomachs that were obtained from autopsies without any pathology, and just the tremendous variability of the individual stomach. And the layperson book that Roger Williams wrote, You Are Extraordinary, really should be the subtitle for this talk, as I'm asking you to help our patients understand their biochemical individuality and the reframe that they are unique and extraordinary. So one of the simplest ways to understand the concept is going back in history. So with the description of scurvy by Richard Walter, note scarcely 2 persons have the same complaints where there's found some conformity in symptoms. The order of their appearance has been totally different. And what we're going to talk about tonight is that concept of biochemical individuality as it relates to nutritional deficiencies. The beginning concepts in understanding personalized medicine, I think, is really appreciating the concepts of genetics, the different genetic polymorphisms, some that we understand and can test for, some that we don't, as well as the concept of epigenetics. Epigenetics are those influences, nutrition being oftentimes the most important, that affect the development, the expression of genes, rather than altering the genetic material itself. And here is just an example of that. So I believe one of the most important messages we can share with our patients is genetics is a liability, but it's not a destiny. So when I put this together a few months ago, I just picked up 5 cases that we might not get through all of them, but we'll at least get through 4. And what I tried to do is look at individuals that presented with the identical list of symptoms. And so we took 5 individuals who presented to my office for treatment of depression. These are the general symptoms. They were non-functioning, well, a lack of social activities, and approximately 2-year onset sleep and irritability. So Jim is the first patient. He was a male grad student. He was an athlete, and he was always health conscious, but he began a vegan diet about a year before I saw him, and he started the power yoga, I think is what it's called, where they're in the very high heat, sweating 2 to 3 times a week. And again, very concerned about his health. The symptoms presented, very similar to all the individuals we'll be talking about: depressed mood, unable to continue school, insomnia, and irritability. So an athlete, power yoga, vegan diet for a year. Before that, essentially a vegetarian diet. So for all the cases we'll discuss, in my practice now is kind of a secondary referral for patients who've struggled with other treatments. I end up doing all the functional medicine tests that I can on initial presentation. You'll see this slide a lot, but for Jim, 23-year-old, we looked at trace minerals, vitamins, food allergies, hormones, amino acids, fatty acids, organic acids, genetic testing, and a host of other kind of routine metabolic testing. And for this individual, everything was completely normal, except he had a B12 level of 234. He had what I call low levels of zinc. It was in the normal reference range. It was a little over 70, and had a low white blood cell count and low alkaline phosphatase. So what I want to share with you is a little bit about B12 and zinc in the treatment of depression, and then I'll come back to Jim. B12, like we discussed with in scurvy, has tremendous variability in symptoms. I have large numbers of patients with B12 deficiency. Some might present with just pure physical neurological problems like fatigue or a tremor, and someone else might present with only a psychological problem, be it depression, apathy, or even psychosis. So tremendous variability in symptoms, and here we see some of these early neurological symptoms of B12 deficiency can be confused with a very serious chronic neurological illnesses from Parkinson's to multiple sclerosis. The literature is very poor. There's mostly scattered case histories with relatively few review articles and summary of how B12 deficiency affects mental health. This is just a random sampling of the literature in the 70s and 80s. Last one is in 1996. And you see the tremendous range of symptoms presented in the psychiatric literature, from severe mania to suicidality to postpartum psychosis. The literature is growing now on low levels of B12 associated with cognitive decline, memory, and actually decreasing brain volume. Those with B12 have the smallest brains and the lowest test scores. And here we have a concept of looking at B12 deficiency as a model for prevention. B vitamins were given to 133 people over 70 for 2 years, and they found that B vitamin therapy prevented the memory decline, and particularly those associated with high homocysteine levels. So homocysteine is an incredibly helpful marker for looking at the functional B12 deficiency, as well as B6 or folate. In this case, there was not an elevation of homocysteine, even though there was a deficiency in B12. Again, this gentleman had zinc and B12 deficiency. Zinc, we've talked about it a lot. It is commonly associated with depression, we'll get to, but some of the early symptoms are lack of taste. We see it in the elderly. I see it a lot in our patients struggling with eating disorders. So our taste receptors are zinc-dependent enzymes, so as we become zinc deficient, food doesn't taste as well. That's why elderly sometimes just don't enjoy eating. Zinc is not only critical for taste, it's critical for proper digestion. Zinc is required for the synthesis of hydrochloric acid, so all the acid produced in the GI tract is a zinc-dependent reaction. And zinc is also critical for all the digestive enzymes, so all the pancreatic enzymes to digest protein, carbohydrates, and fat are zinc-dependent enzymes. So we have a vast number of GI-related complications from zinc deficiency. The importance here of the acid is in the breakdown of protein and to amino acids to get our precursors to all neurotransmitters. Here is a kind of overview of some of the zinc deficiency effects. Zinc is required in the synthesis of serotonin as well as melatonin. We talked about the GI digestive enzymes and acids. So zinc deficiency causes nausea and bloating, lack of pancreatic enzymes. There's a literature on vulnerability to stress. As zinc gets lower, we have poorer stress tolerance. Zinc is required for essential fatty acid metabolism, decreased appetite, attentional difficulties, and depression. The literature of depression is growing. A lot of it is from Europe, but here are some of the studies. The serum zinc levels inversely correlated with depression. A study adding zinc to a multivitamin showed decreased depression scores. And then those that received zinc had lower ratings for, these are 2 depression scales, Hamilton rating and the Beck Depression Inventory compared to placebo. Here's a 12-week study adding, again, 25 milligrams of zinc. And then this is a newer study in the past couple of years, what's called a meta-analysis, looking at many other studies, over 1,600 depressed, 800 controls. Zinc concentrations were lower in the depressed subjects. And again, a summary of lots of studies demonstrating a correlation between low zinc and depression. So this particular gentleman, the first case that we discussed, I won't go back to, but this was Jim. He was the athlete. He was a vegan. He was doing the power yoga. You lose zinc through your sweat. Zinc obviously is more easily accessible, as is B12 in animal products. So a long-standing vegetarian who's currently now a vegan. When Jim came in with his parents, he did not want any medications, although he struggled with pretty significant symptoms of depression, again, interfering with his school. So the only interventions for Jim was B12 injections. I typically use 1,000 micrograms of methylcobalamin 3 times a week for 4 weeks, and increase another 4 weeks if needed, as well as zinc. I rarely go above 60 to 90 milligrams for 4 to 8 weeks. And if I'm using 90, I cut back to 60 and then add a little copper. I've seen too many patients on zinc therapy over the course of an extended period of time where they develop a copper deficiency. So Jim presented depressed. What the theme for this evening is, we don't have a standard of what nutritional interventions to give for someone who's depressed, just like we're asking our colleagues who prescribe medicine to not treat depression as a Prozac deficiency and give everyone who's depressed an antidepressant based on the symptoms. So here we had Jim, depressed, not functioning at school, insomnia, irritability, and zinc and B12 are the only interventions. And he got better. So here's our next case, James. So he was a very bright law student. He was smoking marijuana daily. History of depression since early on, high school, college, multiple therapists, anxiety and panic attack, and multiple antidepressant trials with minimal relief. Again, his presenting symptoms to me were similar to Jim: impaired function at school, lack of interest, insomnia, and irritability. James was, and his family was not as rigid and open to medications if I felt that they were necessary. So what do? We did the same testing that we do on everyone that walks in the office. Complete battery of hormones, amino acids, fatty acids, genetic testing. And what I want to share with you is that the minor abnormalities, the vast majority of all the tests for James were completely normal, except for his total cholesterol being 110. So James was not health food. He ate meat. He ate fast foods. He had plenty of saturated fat and cholesterol in his diet, but his total cholesterol was 110. So we've discussed in the past that our no-fat, low-fat crave over the past 25 years has done very little for the obesity epidemic, and hopefully you will understand how it has wreaked havoc for the mental health community as well. So low cholesterol is a significant risk factor in my experience for depression and what we call treatment-refractory depression. Some of the earliest studies that started confusing us was this original study in New England Journal of Medicine, where our total cholesterol levels went down, from in this study from 190 to less than 140, and there was a decreased heart attack, but the all-cause death rate was almost double. So there was clear literature since 1980 that lowering cholesterol was not good. And over the years, we've been able to find studies associating low cholesterol with multiple mental health problems, including violence, aggression, depression, suicide, stroke, recovery from substance abuse, and even studies looking at school suspensions. These are just some of the studies here. 4,400 male veterans, lower serum cholesterol, high risk for death, 7 times more likely to die prematurely from accidents and suicide. And then studies on suicide victims had much lower cholesterol content from age-matched controlled deaths who were not violent suicides. The cognitive effects of low cholesterol is now part of the FDA warning think we have that. So after, I don't know, 20 years of statin use, the FDA now has a warning for cognitive concerns. This is some of the work of Dwayne Graveline describing his concern as he started taking statins, lowering his cholesterol. He developed chronic memory loss, and has been writing about it ever since. Here's a study with low cholesterol and relapse rate at 3, 6, and 12 months after discharge. Those with the lowest cholesterol had the highest risk of relapse. The neurophysiology is quite simple, actually. That low cholesterol is required in the membrane of all neurons. It helps kind of bind the serotonin receptors as well as the oxytocin receptors, and so low cholesterol reduces binding of serotonin to the serotonin receptor. 60% of the brain is fat, and the brain is a very fatty, cholesterol-rich organ. Every steroid hormone in the body requires cholesterol as a precursor, and there's over 250. Bile salts require cholesterol, and vitamin D is synthesized from cholesterol. It has critically important value for brain health, optimal brain health. And in the gentleman that I saw with a total cholesterol of 110, it's really important to understand the effects of low cholesterol. In my experience, these are individuals that had a poor response to antidepressants. They've been chronically depressed. They're usually associated with aggression or violence, sometimes been diagnosed with bipolar disorder, oftentimes self-injury. One of the things that I have found over the years, not seen any research to support it, but my clinical experience is that those with low cholesterol, once they try marijuana, tend to be very drawn to it, if you will, that it somehow decreases their symptoms more so than other individuals. And I have found in my experience, until the cholesterol level is restored to normal values, that the addictive piece of the pot smoking persists. So this particular gentleman, James, was actually treated with cholesterol supplements. He required up to 6 a day of the cholesterol supplements from the beginnings. We did not have an increased cholesterol in his diet other than try to change from junk food to eggs, eggs being probably the most concentrated source of cholesterol. And he's someone that for a number of months, there was only dietary interventions with the cholesterol and psychotherapy, and after 2 months was started on a antidepressant, Wellbutrin, something that he had tried in the past and had significant side effects to, but was able to tolerate it, and actually recently saw him back, and he's doing well on a low dose of Wellbutrin with cholesterol. His cholesterol got up to about 155, and then as we cut back, went down to 145, and we just monitor it twice a year. I believe the low cholesterol is genetic. Most of the kids that we're seeing, if we test the family members, is usually a parent or someone else in the family that also has very, very low cholesterol, unrelated to diet. Okay, next case. So here we have Jimmy. We went Jim, James, and Jimmy. This is an individual dropped out of college due to his depression, had a history of trauma, sexual abuse by a priest, said alcohol and pot use, occasionally binge drinking, more isolative, doing odd jobs, but really not gainfully employed. Has gained 40 pounds since starting college. He's 23 or 24 as well. And again, the same core symptoms of the other individuals: depression, lack of interest, this gradual onset, and insomnia and irritability. Getting sick of this slide, but I believe it's really important to understand that for everyone we see, we're not prescribing a blanket set of treatments. We're looking at individual metabolic profiles with our functional medicine testing. So this individual did not have any major deficiencies, but he had two, what turned out to be very significant genetic polymorphisms from the genetic testing that we do. So he had the MTH variant, the TT. We'll talk about that, how one metabolizes folate, and the COMT genes. COMT is the enzyme that breaks down dopamine, and he had the very, very slow breakdown of dopamine. So let's talk about these two genetic mutations and how it affected treatment for Jimmy. The MTHFR gene, I think, is getting a lot of hype and maybe a little too much in terms of the internet and how some people are interpreting. Many people are seeing NET allele as this death sentence. So if CC is the normal variant, it's only 30% of the population. So over 50% of the population have one T allele, so that's CT polymorphism, and there is some increased risk of depression with CT, about 1.5 times, not quite 1.5 times. But the real concern in my clinical practice and in reading the literature is that TT. There are differences in the literature from 10 to 14%, but say a smaller number of individuals with TT polymorphism. It has twice the risk of depression, and what we're finding is also twice the risk, or not twice, the studies aren't been done, increased risk of other inflammatory and neuropsychiatric illnesses. This is just a simple kind of visual kind of graph. This was looking at DNA repair. You see enzyme activity for the normal was 100%. It's less with the CT variant, and it goes down to 34% in TT. So it never goes down to 0, which means there is activity and there is L-methylfolate that's being made, but it's at much, much lower rate. The literature in folate and depression is long. I did a study, a research paper on folate and depression when I was in residency, and that was over 25 years ago now. The literature is quite clear that low folate is associated with an increased incidence of depression, a poor response to antidepressants, and a higher rate of relapse. And adding folate can enhance the effect of our current antidepressants. So we have hundreds of studies looking at this relationship, and they're really, really quite simple and quite clear. Probably more research than we have for most of our other treatments in mental health. Here's a simple schematic from an article published a number of years ago in the Journal of Psychiatry. With folate deficiency, you get an elevation of homocysteine and a decrease in SAMe. So we have impaired methylation, started to methylate the neurotransmitters. Medicines don't work as well. Adding folate, we have enhanced synthesis of SAMe, restored methylation, and we have enhanced clinical response. Of the hundreds of studies that I shared with you, this is just one example. It was done at Harvard Medical School, Mass General Hospital, 28 weeks of Prozac, fluoxetine treatment of 40 milligrams a day. So the patient's depression improved, but if you look at the relapse rate for those with low folate, low serum folate, unrelated to their genetic polymorphism, it was 42% versus the relapse rate for normal folate, 3.2%. So really a dramatic difference. But again, we have good research showing increased incidence, poor response to antidepressant. Here's our relapse rate study. And then adding folate to the antidepressant, we have an enhanced clinical response. This was just so dramatic. A simple blood test helped predict relapse rate in depression. You know, folate folate deficiency is common. Let's start with, in my world, the most common, which is the medications. Often, many of our patients are taking a mood stabilizer or anticonvulsants, which all interfere with folate deficiency, alcohol, birth control pill, antacids, metformin, all interfere with folate absorption and utilization. And for many of our patients, just cooking and not canning and processing decreases availability of folate. So folate deficiency is common, and we don't have here is, well, the malabsorption. Many of our chronic GI problems, particularly celiac disease, have a very, very significant decrease in folate absorption. So this individual had the TT variant and also had the MET variant of the COMT gene. So I want to go over that, and then we'll put it all together. Well, let me just share that this individual was treated with L-methylfolate, initially 15 milligrams. I used for a couple of months with the TT variant, and then decreased to at least 3 milligrams of L-methylfolate. So folate with one treatment for this individual. And here is just a little deeper understanding of this COMT enzyme. There are two genetic variations that we're looking at, the VAL-VAL, MET, or VAL-MET. VAL-VAL is this higher dopamine degradation, and which means we try to enhance dopamine production. And then the MET, which this individual had reduced dopamine degradation and a hyperdopaminergic state. So we want to be careful about amino acids. Sometimes tyrosine can be aggravating. Sometimes stimulants can be aggravating to these individuals. So what we have found helpful for the MET variant is the use of SAMI. So SAMI is going to provide support for both the neurotransmitter synthesis and the breakdown of dopamine in the synapse. So SAMI, lots of research looking at SAMI. This is just one study, but to summarize, 800 milligrams twice a day is typically the target dose. Occasionally, some individuals get better on 400 to 800 milligrams, particularly as an augmentation effect, but oftentimes we need to get up to the 1600. This one study, American Journal of Psychiatry, same group at Harvard Medical, these were individuals who did not respond to the SSRI, and then SAMI was added, 1600 milligrams of SAMI was added to the SSRI, and there was a significant difference in response for those that took SAMI and those that didn't. It was a 6-week trial. SAMI can be real helpful. The limiting factors are obviously cost, and in my experience, family history of bipolar illness would limit my use of SAMI. So rather than going back, just to share with you, there were no significant nutritional deficiencies on a large metabolic panel for Jimmy, but he did have these two enzymes, the TT variant, I have found very consistently associated with poor response to medicines in the past. So Jimmy was given Deplin, which is high-dose L-methylfolate, and then switched to nutritional L-methylfolate, 3 milligrams per day, and was given SAMI. SAMI, I start off at 200 milligrams twice a day, and I titrate up over the course of 4 weeks, and eventually did get Jimmy up to 1,600 milligrams of SAMI with a significant improvement in his mood. Again, if you remember, there was a trauma history, there was a substance abuse history, but it wasn't until he was treated where after a little over 2 months that are able to better utilize therapy. He attended therapy regularly, and I've seen him now for over the past year, and is doing quite well. So Sammy, for the treatment of depression for those individuals with this MET variant of COMT gene. Okay, here's the next case we have. Again, let me give you the symptoms that all these individuals had: depressed mood, not doing well at their job or school, gradual onset insomnia and irritability. I chose these in particular because these were nutritionally very simple. Many of the individuals we're seeing might have nutritional deficiencies, genetic vulnerabilities, and GI problems. So I chose these as cleaner illustrations. So Jimbo was a chef, had multiple jobs, and his presentation, besides his chronic depression that his girlfriend described, was this intense irritability and essentially rage. At home it was anger and temper tantrums. In the car it was road rage that he couldn't control, and his girlfriend was both embarrassed about it, and he was asking for help. Family history is an important part of our assessment. This individual had a history of alcoholism and bipolar disorder and multiple suicides. Same functional medicine testing, nothing significant, although on the trace mineral hair analysis, we had undetectable lithium. So this is a test that I do on everybody that I see. I look for heavy metals. I look for ratios of trace minerals, and then looking at lithium levels. The slide on your left is more common, that the vast majority of people that are testing have lithium. It's essential for brain function, and the slide on your right, undetectable lithium, was the case of Jimbo. The treatment was essentially a nutritional lithium for this patient, and I just want to share a little bit about lithium and low-dose lithium. So it's an element that's discovered in 1818, and in 1949, a psychiatrist in Australia was doing studies on guinea pigs using lithium as just a kind of an agent that he put in to help dissolve uric acid crystals, and he noticed that guinea pigs became calmer, and then he started using it on patients and noticed a calming effect. The history goes back to early use as a agent for hangovers in the 20th century. Wake Up was a lithiated drink that was used to help hangovers. And 7-Up, 7-Up, our soft drink, contained lithium until 1950. And if you go back to the weight of lithium, I think it's actually 6.97, and here you see the 7, the atomic weight of lithium, and some believe that's how they got 7-Up, lithiated lemon soda, and it was supposed to lift your spirits. But in terms of mental health, low-dose lithium has profound effects on brain function and mood, and the literature is quite clear about suicide. This is just looking at prescription lithium, which I essentially can't use anymore due to side effects, but here of 300 bipolar patients on lithium, suicide attempts decreased at 7-fold. They stopped the lithium, suicidal acts increased 14-fold. The first year off lithium, suicide rates rose 20 times. Lithium is a few anti-suicidal medications that we have in psychiatry. There's another study looking at the same thing, tremendous difference a meta-analysis, lithium on depression, 88.5 lower suicide risk. It's really dramatic. But again, I shared with you the high-dose lithium, prescription lithium, if you will, has side effects. I rarely use the higher dosages. It's important to know that the essential fatty acids can help prevent a lot of the side effects of lithium. So whenever I prescribe lithium, I do recommend essential fatty acids. But it's this low-dose lithium that we use in our practice that has, I think, tremendous neuroprotective value. And here is just one of the 3 of the studies looking at the lithium in drinking water. And this could be anywhere from 0.5 to 2 milligrams. And these are some of the studies looking at just the water, lithium in the water from 27 different Texas counties, 18 municipalities in Japan, and multiple measures in Austria, all showing the same thing, low levels of lithium associated with higher rates of depression, aggression, and suicide. And then there was an article in September, a New York Times Sunday opinion paper, where somebody, a psychiatrist, actually went to a lecture about lithium and its neuroprotective effects, its current research on preventing dementia and Alzheimer's. And this woman, I believe it was a woman, Anna Fells, kind of asked the question, what if microdose lithium were again part of our standard nutritional fare? The research states strongly suggests that suicide level would be reduced, perhaps other violence, maybe even dementia rate would decline. We don't know because the research hasn't been done. But she put together the literature that I just shared with you and asked the question, and there was tremendous outbursts of anger and rage about comparing a lithium, trace amounts of lithium to fluoridation of the water. Lithium is a natural, a critical nutrient for brain function. Again, it is neuroprotective, meaning it helps prevent nerve damage due to cell injury from many neurotoxins that have been studied, and it actually enhances neuronal growth. So we see this extension of dendrites and neuronal healing with lithium treatment. I think it has a tremendous potential. The clinical use of lithium in my practice, what I want to share with you this patient, is that those individuals with a family history of alcoholism, those individuals with a family history of bipolar disorder, even though the patient in front of you does not meet criteria, doesn't have bipolar disorder, are the ones that have been particularly helpful, particularly good responders to low-dose lithium. I use between 5 and sometimes 20 milligrams of lithium orotate. I usually end up between 5 and 10 milligrams, and that's what this patient took. So here's our last case, and this was a professional, both his parents from the medical field. He had long-standing social anxiety. He was very, very bright, but diagnosed with Asperger's, increasing isolation, anxiety, and some compulsive behaviors and obsessive thoughts. But his presentation to me was this increasing depression, depressed mood, insomnia, and irritability. Again, same genetic profile, and same functional medicine testing, including genetic profile, and the most significant finding was an elevations of the HP-HPA, which you've been hearing about a lot, and I encourage anybody that treats mental health issues to understand elevations of HP-HPA on the organic acid test. It's structurally similar to dopamine norepinephrine. It's a metabolite of phenylalanine produced by Clostridia species in the intestine. I think you've seen this. The Clostridia bacteria produce the HPA, which we pick up in the organic acid in the urine. HPA is neurotoxic, if you will. Here's a schematic diagram. What we see is the HPA prevents the conversion of dopamine to norepinephrine, inhibiting the dopamine beta hydroxylase enzyme. So we get this buildup of dopamine. And again, this concept of biochemical individuality is really important, because I could have that same 750 or 796 for this patient level of HPA, and we might get a wide range of neuropsychiatric, psychological, or physical symptoms. We've seen schizophrenia, tics, Tourette's, from autism to OCD to pure depression. It's usually an agitated depression or an OCD depression, or similar to the patient we described, kind of an Asperger's-like history with depression. But it can be debilitating. What I share with patients is that these elevated levels of HPA, it's hard to predict exactly what the symptoms are, but I pretty much, looking at this test for over 20 years, individuals just don't feel well. So if you remember, we have this elevation of dopamine due to this inability to synthesize norepinephrine. If we have this elevation of dopamine, if we go back to our first slides of biochemical individuality, an individual that has HPA might experience some symptoms. But if that individual also has that genetic variant of that MET in the COMT gene, what does that look like? That individual is going to have elevated dopamine, but is going to have reduced dopamine degradation. So there are two mechanisms where there's going to be a hyperdopaminergic state, if you will. So that individual is going to be intensely agitated, is the only way that I can describe it. And again, a really important concept, elevated HPA plus a genetic variant in how one metabolizes dopamine will affect clinical symptoms. HPA is a nice marker that can be easily treated. We use high-dose probiotics. I use between 100 and 200 billion. For some individuals, that I found sufficient to decrease HPA. For others, we use vancomycin. It seems like the most efficient protocol is taking vancomycin over an extended period of time with 1 day of the antibiotic and then 2 days off to extend the period of time so we don't get spores that will end up growing after the antibiotic has stopped. So we've had tremendous success decreasing HPA and improvement in symptoms. This is just a summary of how important the microbiome are to our functioning. There are 10 times more microorganisms than human cells, but more importantly, the microbial genes to our genes are 150 to 1. So the human body has around 22,000 human genes, over 3 million bacterial genes. No one has the same microbial makeup, and hence the driving genetic influences of our microbiome is different and can affect everyone. So, what I hope to share with you a little bit is that there's no one treatment for depressed mood. These are individuals, all young gentlemen, I think somewhere between 23 and 28. And the depression was different. So too many times our integrative colleagues, our functional medical colleagues, kind of use the same concepts that we try to speak against, which is one size fits all. Depression is a deficiency in X. So people get on their, bandwagon and say everyone needs B12. More commonly we hear everyone needs 5-HTP. everyone needs folate. Well, that's not necessarily true. Everybody's different, and we need to begin to understand who that patient is in front of us to be able to effectively treat them. And we'll just keep going back to everybody's different. We talk about asking our patients to eat right, the benefits of mindfulness, the benefits of exercise, the benefits of all the healthy lifestyle choices, that the research is quite clear. But if we take our kind of concept of, let's say, someone who is just unable to relax due to their biochemical makeup, might find meditation, certain types of meditation, harder, and they might do better with more exercise or more energetic kinds of yoga. Everybody's different, and we need to understand that. And we talked earlier about exercise being the best antidepressant that we have, but there are only a subclass of individuals that are going to have the energy to get out and do what they know is right. I was going to get up early to go running, but my toes voted against me 10-1. So essentially, psychiatry is different. We don't have objective measures to use, and our whole approach is symptomatic relief of symptoms. And what I tried to share with you, looking at the same few symptoms, is can we do a better job at looking at physiology? Can we do a better job looking at metabolism, hormones, neurotoxins, and seeing what deficiency states are available, and then use treatments based on that physiology, based on what we do in the rest of medicine. We do a chest x-ray, and we know exactly what we're treating. We're not taking educated guesses, and then as patients improve, we're moderating that physiology. The symptomatic-based treatment essentially provides us with a medication, a goal. So we just use one medication and then the next. We drive down this polypharmacy highway with increased side effects, and essentially we haven't done as good a job as we would like. 66% patients treated with antidepressants have residual symptoms. 20% incapacitated or committed suicide, and the relapse rate is profound, 40% within 15 weeks. Poorly treated depression, not looking at the metabolic picture, depression becomes a chronic relapsing illness with a higher rate of disability than most of our major chronic illnesses, and depression will become the first worldwide cause of disability by the year 2020. So the approach is pretty simple. We have people spit in a cup, pee in a cup, look at trace minerals, blood tests, is whatever we can to find out what is going on for this individual. And the concept of mastering balance, looking at that genetic vulnerability, looking at currently what's happening, and helping our patients not look for perfection, but look for peace of mind. And that genetic vulnerability is a really important factor in that. So modern medicine has evolved into one of the most spiritually malnourished professions that ever existed, Larry Dossey. And if we can target these therapeutic interventions to the biochemical imbalance, we're going to have improvement in rates of remission and recovery. I can share with you one of the most significant parts of utilizing a functional medicine approach is that, one, if we use medicine work better, and two, the relapse rate and the relapse rate is low and the remission rate is high. So in integrative psychiatry, personalized medicine, we look at mental illness as errors, multiple errors in physiology. And then if we find the cause, and there might be many causes, we can begin to look at concepts like cure and remission, something that's rarely integrated into psychiatry. And sometimes we tend to oversimplify, and looking at a B12 level is going to be the answer. Well, it's certainly helpful, but this was an eating disorder patient, had profound zinc deficiency, And it's just in my example of it's not always simple. So a chronic eating disorder patient, she started taking liquid zinc, 3 days, had an appetite. I felt hungry, first time in years. I felt scared, and I stopped the zinc. So as mental health professionals, we're constantly looking and using all of our tools, our lifestyle tools, as well as our therapy tools in the context of improving the biological foundation to get treatment. So we're close out of time, but I can take a few questions, maybe for 10 minutes, if individuals have questions. Okay, so I have a few questions. So a lot of questions on the genetic polymorphism. So let's start there. So the VAL and the MET variants. So for the VAL, which is the quick breakdown of the efficient breakdown of dopamine, supplements, we would use the tyrosine or phenylalanine precursor. And I've had individuals had poor response to antidepressants, and tyrosine was incredibly helpful for that variant for the treatment of depression. So we would look at enhancing dopamine, phenylalanine, tyrosine, and then the cofactors, particularly folate and zinc. So the question is the methylfolate. I do use methylfolate. I use between 3 milligrams and 15 milligrams. I didn't talk about the other A1298 variant. That is something that we look at and would clearly provide optimal folate for that. I have not seen it as significantly correlated with depression, although it's certainly important in providing adequate folate. So B12 with high levels. I can share with you some of my anorexic patients who haven't eaten meat, have some of the highest B12 levels of anybody I've seen. So there's a lot of good literature demonstrating that serum B12 levels do not adequately reflect CSF, cerebrospinal fluid B12 levels. There's some early studies looking at demented patients. They had normal blood levels and did a spinal tap, and they had no detectable B12. So B12 is one of the few nutrients that I would treat based on clinical symptoms, fatigue, cognitive impairment, serum levels being low, elevated homocysteine, and or methylmalonic acid being elevated in the urine or the serum. So the serum levels of B12 are not adequate to determine B12 deficiency. The question is rhodiola. Rhodiola is in some of the dopamine-enhancing supplements that we use. I think rhodiola is a very nice support for dopamine metabolism. We use anywhere between 100 and 600 milligrams of rhodiola. Oftentimes it can be stimulating, so be careful in bipolar patients. But it does help support some dopamine metabolism. Got a couple more questions, and then we'll stop. Retesting to establish the efficacy of treatment. And what tests we use what do we retest? So pretty much everyone coming into our practice, I do look at that large battery of testing at first, because otherwise I'm just making educated guesses, and the patients I'm seeing have struggled for too long. Oftentimes, my retesting is very minimal. I know after one injection of B12, the serum level is going to be elevated. I don't need to retest that right away. I do retest HPA in 3 or 4 months of vancomycin and probiotics. I do repeat the organic acid test. I don't often repeat the amino acids, the food allergies, or the fatty acids, except for 6 to 12 months in yearly interviews. We base most of our retesting on clinical improvement, and some of the fat-soluble vitamins like vitamin D, cholesterol, we would want to recheck to see if our interventions are making a functional difference in any of these biomarkers. I appreciate your time this evening and patience for those on the East Coast. I'm being so late, but I hope I was able to provide a kind of an overview of the importance of a really personalized approach to integrative medicine, and testing being the core part of that modality. Thanks again, and have a great night.